in the ED.
All right, and I'm Ariana Campbell. I'm a PA. I think Nick, you said physician. I just want to clarify, I'm PA, and yeah, I'm really happy to be here with Josh and amazing experts in the field, and this is very exciting. So next slide. I did want to start with our disclosures, which is that we have none other than we both Josh and I are paid directors at California Bridge, which is a grant-funded organization, a program of the Public Health Institute. All right, next slide. I'm going to breeze through some things because, but first we're going to start with a poll question, and then we'll talk about some things just to really get into what we're doing at California Bridge. So here is the poll question. Do you feel your hospital, clinic, or treatment center treats addiction as a chronic disease like diabetes and provides rapid, high-quality, evidence-based treatment? Poll questions are fun. So we'll see how everybody responds.
All right, about 68% have responded. All right, let's end poll. Would you like to share the results?
Yeah, I don't see them, but what are the results here? Let's see.
Oh, good.
So good. So a majority do feel like their hospitals and clinics are treating addiction as a chronic disease, and providing rapid, high quality, evidence-based treatment. So that's great. What we're going to talk about is really improving that system and providing excellent navigation to high quality care.
Right, and that may be when the poll responder is working on shift. So part of the whole having a treatment team and having a substance use navigator is so that when you're, the people who are at this meeting are probably more likely to be advocates. We want to have even care for whoever is working on shift.
Exactly. I always say the best things are when I do a review of the folks that we've treated and I find that others are providing that same high quality treatment. So, all right, so next slide. I'd like to talk a little bit about the foundation of what we do at California Bridge, which is really, we're trying to revolutionize the system of care. And there's 3 pillars of that, which I will just discuss briefly because this is really the foundation to the work we're doing. Number 1, rapid evidence-based treatment. We treat patients very quickly without them having to jump through a lot of hoops and be miserable. We want to decrease suffering and increase their access to rapid evidence-based treatment. We also, another pillar is connection to ongoing care. And really this is low barrier, high quality care. And then the last part of it is culture of respect. And we really find, and I say that the way you look at somebody, the way you talk to somebody, especially in an emergency department setting or hospital setting, can save lives because it encourages safety. So safety of folks to disclose what's going on in their lives with highly stigmatized conditions. And it can save somebody's life just to know that they're safe coming to the emergency department or hospital. All right, next slide. So really, again, foundational is that we treat addiction as a chronic treatable disease with these acute moments of life-saving treatment that we can administer in the emergency department and hospital setting. It is not a moral failing. And this is really important. And again, the base of everything that we're doing at California Bridge and across all these hospitals in the state and really across the country. All right, next slide. So we all know, and it sounds like the folks on this call, the vast majority do know that the benefits of treating with the right medication. I always say the right medication at the right time to the right patient, which is anytime somebody is seeking care for this, right? That we save lives and we decrease mortality significantly with the right medication. All right, next slide. And where are we doing this at California Bridge? Well, we have had the advantage of having widespread uptake of the model that we're utilizing. And we'll talk, Josh is going to get into the model, especially with the navigation that we have found to be foundational. But our goal is 24/7 access to high quality treatment of all substance use disorders in California by 2025. And Josh, we are on our way there. So we started with 52 hospitals. So over a little bit more than a year, so 15 months time, we successfully implemented programs at 52 hospitals in California. And then we received funding for navigators in 208 hospitals, which we are currently implementing. And we are very close to reaching our goal of universal access. And so what that means is our goal is that somebody could wake up in the morning and say, today's the day I'm going to get treatment. and they will be connected. They'll know, just like if they cut their hand or if they had something else going on, okay, I can go to the emergency department and they're going to help me. And then that they will get evidence-based, high quality treatment and referral to a place that will accept them with open arms and give them the same type of evidence-based treatment without barriers. That is the vision. And we are realizing that vision because we have this model across California and really the standard of care in California. So we're very close. We are going to be implementing at even more hospitals in the very near future. All right, next slide. So we want to talk about navigators because this is the secret sauce. So these are the change makers in the hospitals, and really this model, this idea has created such quick change. In fact, we've treated thousands and thousands of patients at hospitals in California because of our navigators. And really what we know, and this was a quote from Carmen Navarez out of PHI. She's the national, actually overdose prevention leadership at the National Opioid Leadership Summit in 2020 said the opioid epidemic will take more than one person and one profession. And that is the idea, is that we need this group of folks who can drive this change. Next slide. This is just an example. This is my navigator out of Marshall, but really importantly is we actually are proud of our program and we utilize signs so that folks know that they can safely disclose any use disorder, and they will be met with open arms and somebody who can talk to them, who is educated in motivational interviewing and knows all the resources in the community. Next slide. We're going to skip through the case, though, we talked about if you're doing, are you utilizing evidence-based high quality treatment in your emergency departments? Most of you are. We also know that staff and community need to be involved. So we know that that these navigators are role models for change, and certainly having a navigator in your department can reduce stigma, biases, support your ED team, and you build these trusting relationships with patients, families after discharge. So there's a safe place to land, and even a phone number that folks can call if they find themselves, in need of care. Next slide. All right, so I'm gonna have Josh talk about the model, really get into the nitty-gritty of the model here.
Okay, so this is part of understanding the substance use navigator role is to break apart their interactions with the patient in the stages of the patient journey. So on the top, it just shows, basically the substance use navigator being engaged, and that early engagement in the inpatient care is ideal. And then you have the patient journey, pre-visit, ED lobby, waiting room, greeter desk, triage, in the treatment area, and at discharge. So at each step along the way, the substance use navigator can be engaged ideally early in the process. And throughout, they're going to be modeling compassionate, destigmatizing language and behavior and helping the process along. Next slide, please. So starting off at the beginning, so the pre-visit. So the substance use navigators have this pre-visit role where they are receiving referrals that are coming from multiple places. They can be coming from sober centers, detox facilities, community clinics, out of county patients. Like I have someone from, you'll have patients coming between, patients are highly mobile. So they're heading from one county to another. So they'll contact the substance use navigator at the safety net hospital in X county and let them know that there's a patient coming in. Patients are self-referring. They may have a friend who got treatment. They saw maybe the phone number for the substance use navigator on a naloxone kit that went out. We like to label our naloxone kits. And so they're calling in and saying, hey, I heard I can get help. How do I get help? And they're helping to do this pre-navigation engagement. And when they get those calls and that input of someone who's coming in, then they can say, hey, great, what I need you to do is not use heroin until, I want you to be in withdrawal, and we can actually dose you right in the ED. So they kind of can do some coaching so that the patients know how to come in, and they can say, why don't you come in early in the morning? We're not busy, that'd be the best time. Or you're in an emergent situation, you can come in right now. Or maybe you just need a refill and you don't even need to come to the ED. And they're like, oh, I'll get you that clinic appointment. I'll get that doc to do the refill. Like they can do a lot of pre-visit navigation. And the triggers are, this is also as far as the stakeholders. So this is a community at large, primary care, the MAT clinics, homeless service agencies, law enforcement, sobering centers, syringe access services. All of them are interfacing with the substance navigator as a pre-visit part of the patient journey. Next slide. Once the patient hits the ED lobby or waiting room, this is where your signage comes into play. So the signage is that Ariana shows where you have, it's like, it lets people know that this is a safe place to disclose that they have a substance use disorder, and that they will receive meaningful treatment. So for example, you may have patients, and I know we all have patients like this, who are coming in for back pain, abdominal pain, chest pain, dental pain, again and again, and underneath all this is an underlying substance use disorder. When they see these signs, it can reframe the entire encounter. And now they can ask for help. And then that help comes immediately in forms of a substance use navigator who meets them, acts as an ally, an advocate, and a greeter, and a troubleshooter right at the beginning of the encounter, and makes it so that it's an actual therapeutic relationship that's getting to the underlying problem. Next slide, please. Again, it's the greeter desk. So not just, now you've made it past the waiting room and you're actually at the triage desk, and the substance use navigator forms a close relationship with the triage staff, so that the triage can, if they've made it this far and the substance use navigator isn't already aware, they can contact, they can page the substance use navigator, call them. Also, the substance use navigator is looking on the tracking board and seeing if there's patients that are there for withdrawal or overdose or intoxication or abscesses or buprenorphine refills. And so they're screening to see if maybe they didn't get, someone at triage didn't alert them. They can also be looking at the navigation board and then, zipping down to the ED to meet with that patient and start that advocacy. Next slide. So the treatment area. So when the son actually acts as a consultant. So they will engage with the patient, start the motivational interviewing, explain buprenorphine and treatment options. They'll do a COWS score to determine their level of withdrawal. They'll be able to offer naloxone, harm reduction supplies, syringes, and they'll report to the treating clinician. So they're providing all this information to the treating clinician to help inform the decision and the care plan. They're also coordinating with the social work services to determine other needs that may be beyond what the son could provide for housing, shelter, all the great things that social work can assist with, transportation. And then they usually drop a consultation note that becomes part of the record. Next slide, please. Oh, one other thing too is if the treating clinician is not X-waivered, the substance navigator is often going around and finding someone who is X-waivered who can provide a prescription. So they're helping with that end of things as well. And then at the discharge step, so they are providing ongoing longitudinal touches. So the care does not stop after the ED care stops. Like they're continuing to engage and troubleshoot all these issues. So someone's going from active use and they've gone through the ED, hopefully they've gotten buprenorphine, they've got a prescription and hopefully a dose. And then now they've got to get their insurance fixed. They've got to make sure that the formulation that they were prescribed is actually covered by the insurance, that they have insurance, and that they have a follow-up appointment. And all those steps and all those issues that our patients face are being troubleshooted by the substance use navigator. And then they're also re-engaging in usually in sort of fixed intervals. So they're, right before their appointment, they're giving them a call. In a week, they're checking in. So there's all this ongoing touches and care. And then at the same time, the patient, when they leave, they leave with the substance use navigator's contact information so that they can re-engage on demand as needed. And so that's that piece of it. Next slide. This is our substance use navigation toolkit. So this goes much more in depth than this quick overview that we have now. And you can point your phone at that QR code on the right and it will direct you right there, or just go to californiabridge.org, cabridge.org, all run together. And you will, there's job descriptions, there's lots of in-depth discussion of this particular role. Next slide. What does success look like? This is the, in the interest of time, I think I'm going to skip through this, but this is a nice little summary. And next slide. This is the video that we're going to skip through. And the website. So again, I want to just bring up the website has been, there are a lot of resources that have been developed on the California Bridge website. I welcome everyone to please visit it. It's also phone friendly, so you can just navigate there on your phone, and it's formatted to work in that regard. There's actually so much content that we do need we have a search, ways to filter and search on various topics, from how to quick rapid algorithms for dosing patients with buprenorphine in the ED, to pregnant patients, to treating pain with patients who are on buprenorphine, on and on and on and on. It goes on and on. So again, please visit our website to access these resources that have been put together with lots of blood, sweat, and tears. That next slide. And then I think we're going to have questions at the very end. So hopefully we made it somewhere within 15 minutes.
Excellent. And there's already a good question in the chat. We'll address it at the end, but I'll put a little bit of information in the chat. We'll answer some questions in the chat and some at the end. But thank you.
Great. Thank you so much,
Thank you so much.
And Ariana. Up next, we have Dr. David Kahn with Telehealth Best Practices.
Thank you, everybody. It's a pleasure to speak with you. And I'm David Kahn. I'm the Chief Medical Officer of Bright Heart Health. The only disclosure that I have is I'm an equity holder in Bright Heart Health. I won't be talking about Bright Heart Health in particular. Why don't we move on to our poll question?
Okay. So what we want.
And our poll question is, if memory serves me correctly, what percentage of your MOUD practice involves telemedicine last month? And it's broken up in sort of 20% increments, except for the last one, which is last two, which are 95% plus, or you're unsure. So take a second to answer that.
All right, we're at about 55% respondees, 62, 66. Give it one more second and close it out. All right.
So interesting distribution here. So it seems like most people fall into the 1 to 20%, although there's a 41 to 60%, but it seems to be a little bit all over the place. So I take it that what's happening is that people are moving back to in-person care in a meaningful way. Next slide, please. So I'll be talking about 5 parts to my talk, and it's structured from the standpoint of from a system level down to an individual. So next slide. So when it comes to solutions for engagement, there's some best practices that I can recommend. Frequent engagement is nice because it builds trust in the relationship. You can do things via telemedicine that you couldn't do. For example, observe medication usage, make sure people are taking sublingual buprenorphine in the correct way. A lot of people aren't very well educated on that. And for patients who are struggling, who need a higher level of support, you can do quick, easy engagements. There's crisis support, and also it gives you a wonderful understanding of where is the patient coming from? What does their environment look like? The pluses are that it's easy. You can use non-providers, like non-prescribers, to do the engagements. And frequent engagement tends to keep people in care, and you make better decisions as you get more information in the moment. Next slide.
Dr. Khan, I think your microphone might be a little scratchy.
Oh, How's that?
That is much better. Thank you. Very much.
Okay. Yeah. And how do we make it easier for patients and providers? We try to keep there's individual meetings. That's good for low volume one-to-one relationships, directly sending a link. You can have a centralized check-in process where you move patients to exam rooms. It's typically in 10 to 25 encounters per hour. There's a distributed model where there's check-in rooms for specific patient tasks, such as appointments, urine drug screens. And then there's a federated model, which there's multiple check-in rooms per task, which is good for high volume. So depending on how many patients you're seeing per hour, you may consider different models. Next slide. Now, of course, we need to make sure people can connect. Next slide. How do we assess digital connectivity? Well, there's some do's and don'ts. The do's: ask the patients if they can text, ask if they can watch videos on YouTube, or ask if they have a social media account. Do not ask whether they have a data plan or not. If they have an internet-enabled device, such as a smartphone, tablet, or computer, they can generally connect, but the data plan is far less important. Just it's a question of what can they actually do with their devices. Next slide. And when it comes to platforms, you can use non-HIPAA compliant platforms during the period of the epidemic. The federal government has suspended HIPAA enforcement during the COVID-19 epidemic, but don't use public-facing platforms such as TikTok or Facebook Live. Most of us wouldn't do it, but just a warning, do not use public-facing platforms. Next slide. Now, there's HIPAA compliant platforms, which we'll all eventually have to get to at some point. And here's a QR code that'll connect you with Center for Connected Health Policy. Center for Connected Health Policy is a great resource when it comes to laws, platforms, and general telemedicine questions. I know most of you are in Illinois, the state near and dear to me. I went to Northwestern for undergrad and medical school, but some of you may practice in outlying counties. So make sure that you're compliant with local rules as well as regulations. Next slide. Now, how do we do informed consent? Next slide. So informed consent, think of the process of telemedicine very much like a different type of procedure. And these are the elements of informed consent before initiating telemedicine that needs to be told to the patient. The short version of it is that we're dealing with technology here, and the information may be insufficient, equipment could fail. Security protocols are in place, but anything that goes over the internet could potentially be seen. If we don't have access to your complete medical records, we may be making a mistake around allergic reactions. Talk about the limits of confidentiality, and very clearly with any procedure, the patient can decide to withdraw from telemedicine. If you make recordings of your conversations, that's part of the record, and the patient has a right to those recordings. Let them know there's alternative methods of care and also a risk-benefit analysis. Remember that the standard for informed consent is a patient-centered standard. And that is in the Supreme Court case Canterbury v. Spence. And these are the things that are relevant to the patient themselves as they decide to engage in telemedicine. Next slide. So what about telemedicine etiquette? Many of us have been on many Zoom calls, and many of us have been on Zoom calls that are not good. Why is that? Well, I'll get into some of the details in a second. Can we get the next slide? I'm being told my microphone is getting scratchy again. I will switch microphones to another place. So that's one thing, is make sure that you have a clear signal. There we go. We'll switch to this one. That should sound a little bit clearer. So as far as the, this is my literal setup. This is where I sit right now as I speak with you. And you'll notice it's complicated, it's messy, much like me in my life, but nevertheless, I have a wide monitor. I'm staring into that very webcam. I run off of a laptop at the bottom, but part of the setup piece of things is just for your information. I see many people staring down into their phones or their computers, and that's a great formula for tech neck. I'm sitting up straight and I want to be seen. The other piece is lighting. I've got a window behind me, which is a backlighting issue. And though this may seem a little bit excessive, suffice it to say, if you're going to be doing a lot of it, you want to present a clear image where people can see and then interact with you. Next slide, please. Now, what are some things that you don't want to do? This is me staring down. It's backlighting. And one of the things from a dress standpoint, I have a fondness for gingham, but suffice it to say, I wear a sweater over it because busy patterns can kind of vibrate on the camera. The other thing about looking down towards people describe it as sort of, the patients describe it, it feels like Godzilla staring over them. Next slide. Looking off into space, you'll notice with my particular setup, I'm looking up and down, not staring off into space. Patients don't like that. You also see the glare in the glasses. Next slide, please. Nostril shot, nobody likes that. Next slide. And the proper look is the look, hopefully, that I'm showing you right now. Good eye contact. I have headphones in place, although as I'm finding out, my headphones are a little bit scratchy compared to the microphone on my camera. But suffice it to say, you want a clear signal. You want to be looking right at the patient. Next slide. So when it comes to patient telemedicine etiquette is that we want to ensure there's privacy. People can connect from just about anywhere, but one of the things that I ask for is that they wear headphones. If you suspect there's somebody else in there, you can have them scan the room. I've been amazed at people, how comfortable they feel with me to frank states of undress. So certainly that's something worth discussing if it's appropriate. And then during COVID, camera is optional. You can do phone only medications for opioid use disorder, but at other times having asynchronous audio and visual is required for billing. Next slide. So how do you diagnose opioid use disorder via telemedicine? And this is where I'll spend a little bit more time because it's something that, how do we make a diagnosis? Next slide. Now, all of you know the Dsm criteria for opioid use disorder. You need to have at least 2 of the following as a result of opioid use. And the severity is scaled based upon the number of symptoms that's present. Having said that, what I found is people who are seeking help, whether it's in the emergency department or specifically interacting with you, they oftentimes will tell you very quickly that they have an opioid use disorder diagnosis. A very typical history is, doc, I need help. I'm trying to stop using heroin and I've tried a bunch of times, but every time I stop, I get sick and return to using. It's cost me my relationships. I can't stop craving it whenever I stop. And in that one paragraph, you've already got a moderate opioid use disorder diagnosis. But the things I'll talk about are how do we, beyond that, look, you've got a diagnosis, but what are some other ways of doing assessments? Next slide. Now, as I mentioned, the history gathering, you ask, how can I help you? Tell me about your drug use, how long and what impacts has it had on your life? Have you tried to stop? One thing that I sort of repeat over and over again, ask about injection drug use. Don't ask about intravenous drug use. Having worked in San Francisco running an opioid treatment program, I can say that I have patients with obvious needle infections and injuries, but they say that they don't hit a vein because in large part their vasculature has collapsed from repeated injection drug use. So ask about injection drug use. When it comes to prescription drug monitoring programs in California, where I live, there's a requirement to check it before prescribing controlled substances. It's required for me within my practice, and it can be helpful, but it's not absolutely critical. Next slide. So remember that patients don't need to be in withdrawal when they are being assessed. Having said that, a patient who's in withdrawal can kind of show you, can very much show that to you in different ways. Some people say you can't see pupils on telemedicine. I would disagree. If you get the camera close, the resolution is pretty good. And these are snapshots I've taken off of the FaceTime app. My wife's pupils in the upper left-hand corner, kind of hard to see, but none of these pupils are dilated. But you can look, and typically it's the image captured over the course of time that you can document. Next slide. So when I think about the physical examination, I think of it in ways that the comedians use their microphones for sound effects, various other approaches. But when it comes to physical examination, you can have them use your camera and look for evidence of track marks. When it comes to withdrawal, for example, if the hands are shaking, I will ask them to put their camera out and stare at themselves, and you can see their hands shaking. When it comes to sniffling as a withdrawal symptom, that's pretty obvious. Yawning is also obvious. And when it comes to the GI, I actually ask them to put their phone or their microphone against their gut, and you can hear the symphony of opioid withdrawal. Sometimes I ask patients to stand up and point at their feet, and you can see them being restless and moving around. What's harder is goose flesh, and as mentioned, dilated pupils are something that you can definitely do. So when it comes to doing a type of assessment, the clinical history is the most important piece, but when it comes to actual parts of physical assessment, you can leverage the phone to your advantage. Now, if it's a tablet, computer, it's a little bit harder to get them to move it around and things like that. One of the things that I will say as a general practice pattern is that through telemedicine, you're mostly doing in-home inductions. This is completely anecdotal, but the success of an induction of buprenorphine is largely levered to access to a private bathroom, meaning that so long as they can get sick enough that they are going to the bathroom repeatedly, having their own bathroom really helps. Next slide. And the last piece is drug screens. Look, we're required to do drug screens, and the way that I do it is actually mail the drug screens to the patient. The procedures that they unwrap the drug screen on camera, they go to the bathroom, and I don't ask to follow them into it. And then we have a look at the point of care drug screen. One line is positive, 2 lines is negative. Now, there's always concerns that people could submit a specimen, but suffice it to say, with buprenorphine, there is a built-in control. What I've heard is people said there's no CLIA wave fentanyl screen. That's actually not true anymore. That is available there. So with that, I will finish up my prepared remarks. And next slide. This is my contact information to get a hold of me. Thank you for letting me have the time. I look forward to answering your questions at the end of the talk.
Thank you so much, Dr. Khan. And next we have Dr. Laura Kehoe.
Super. Hi all, can you hear me okay, Nikki?
Yes,
Okay, great. I'm going to be talking about the evolution of our bridge clinic, which fits obviously perfectly with my other colleagues here. Next slide. These are my disclosures. I'm a medical consultant for a few nonprofits and a non-branded national speaker about chronic illness of substance use disorder for Indivior, but non-branded. Next slide. Starting with a case, this is a 56-year-old female with severe opioid use disorder, major depressive disorder, and complex PTSD. Her urine toxicology screens are persistently positive for cocaine and prescribed buprenorphine, occasional non-prescribed benzodiazepines, and negative for opioids. She frequents the emergency department and recently was diagnosed with a cellulitis from injection drug use, and frequently no-shows to your appointments for buprenorphine and substance use follow-up, and is not engaging with a therapist. Next slide. So how would you manage this? This is a poll question. 1 is tell her that unless she sees a therapist, you'll need to discontinue her from your care and discontinue her buprenorphine. 2, accept that she'll never achieve remission, but continue to be her provider and focus on her depression. Or 3, explore what the barriers are, celebrate the negative opioids, see what her goals are, and deconstruct the role of the cocaine and the benzodiazepines. So go ahead and pick those. And then Nikki, I'll wait for you.
Yes, we're at about 37%.
Great.
50. Get a couple more responders. There we go. All right. And we're at 70, close out the poll and share the results.
Super. So I think I'm kind of preaching to the choir here. This is fantastic. So almost all of you have chosen what we would hope, which is really patient-centered care. And as you heard earlier, it's really kind of approaching this as we do through the lens of any other chronic relapsing and remitting illness. We wouldn't discharge people from care if other chronic illnesses were not perfectly well managed, but we'd kind of focus on what the patient's goals are and kind of center them in the middle of the team here and move along with them. Next slide. So a couple of things, barriers to care, that's the theme here. We're trying to reduce or remove barriers to care in the worst drug crisis our country has ever experienced. And this is actually information that we have from people who use drugs and have experienced significant trauma when they've come for care to a healthcare system that was absolutely not prepared for or welcoming to them. And the numerous barriers that they have described is first and foremost, obviously stigma, that's the umbrella for all of this, but also more logistically, they don't know where to go, how to get there, and balancing competing priorities in their lives like parenting or working, which is why it's so phenomenal having the California bridge kind of spanning the whole state of California. A complicated registration and multi-step intake process. I mean, these intakes that are, 2 parts over several days when people are in the throes of withdrawal, really seeking care, just are not necessarily at all evidence-based and certainly not patient-centered, and certainly don't meet the acuity and the urgency of getting people onto life-saving medication and engaged in care wherever they can start. And often our patients have a difficulty articulating what their goals are and what their needs are. And so just getting them to step a foot in the door, kind of meet somebody, start with a cup of coffee, engage them, might be all they can do at that moment, but that matters. And that's the first step. And then, as I said earlier, probably the biggest piece in this, is the legacy of their past negative experiences with us. They're conditioned not to trust us. So even in the most welcoming, destigmatizing terms and environment, don't expect, even if you're the most harm reduction based patient-centered person, that your patient is going to feel safe with you right up front, and it might take time to engage them and gain their trust. And what low threshold care really aims to do is to just remove these really stringent eligibility criteria to broaden our reach to patients. Next slide. And we did a qualitative survey out of our bridge clinic, and this is a quote that really always moves me, that really underscores the need for more flexible care models. That this patient said, I'm all over the place. Appointments are really hard for me. I don't want to not take the medication, buprenorphine, so I've taken it every day up till now. It's just really hard setting up appointments and then trying to go about things the way other people would want me to do at the hospital. So our goals may not necessarily jive with the patient's goals. And so we need to start where they can go. And especially if someone's chaotically using or experiencing homelessness, appointments can be, a casualty. So being able to flex and allow that open access is critical. Next slide. And here, this growing awareness for the need for these bridge clinics. This was, we started our bridge clinic in 2000, and we started tracking data in 2016 and partnered with our emergency department. And obviously our colleagues heard it, have expanded this incredible continuum through California. And so this is really the model. This is the standard of care that is expanding, and this awareness and movement is really kind of taking hold, which is wonderful. Next slide. In our hospital, we have really a continuum of care that is low threshold, and the core principles are just as you heard earlier. It's a chronic care model, patient-centered, evidence-based, and the quality standards are really throughout the hospital at any stage where somebody may interface or be. So it could be that somebody is coming into OB, somebody's coming into pediatrics through the emergency room, they're showing up at a psychiatry appointment, in primary care, wherever it is, we've created this continuum to allow this low threshold care. Next slide. And really our continuum, more specifically in terms of our addiction specialty care, we have an inpatient consult team, integrated primary care champion teams that includes physicians, nurse practitioners, recovery coaches, navigators, and patient service coordinators. And we also have a Hope Clinic, which is for our peripartum and postpartum families. So mom and baby and partner, if also in need of services for the first 2 years of lives, ED-initiated treatment, and ongoing this consult and return stabilization for our the whole hospital and community health centers. And then our lowest threshold harm reduction based clinic is the Bridge Clinic where I work. Next slide. The Bridge Clinic, not surprisingly, is a harm reduction based clinic that is team based. It's a transitional model, which is how we've been able to keep up this immediate access, walk in, drop in, come as you are. On average, patients stay with us for 2.5 months. And we do have a subset of about 25 to 30% of our patients who have stayed with us longer. And that really underscores that there aren't many places like this where patients who are continuing to have chaotic use or trouble with mental health or homelessness, that they don't have many other options. So this is that subset that largely spans patients who are experiencing homelessness and serious mental illness. In the 6-month average, we see 166 unique patients per month, roughly half male, female with a slight male predominance, not surprisingly middle-aged, under 50. And really 50% of our visits are not scheduled, and we schedule patients just for our tracking. So if people don't come, we do outreach, not that we're expecting them to come at a scheduled time. So it's really an operational way for us to do outreach. And it works, and that's how we've been able to continue support, is that we see decreased ED utilization and inpatient stay. Next slide. The next slide is a little fuzzy, but the kind of big take home of it is when we started, we opened in 2015, but started tracking data in 2016. You can see this steep kind of increase in our volume. And then when COVID hit, we saw a drop off, and this really, really concerned us. So we had this balance between wanting to do telemedicine to help keep people safe in a way and reach them in other ways, but we really needed to keep people coming as well for those who didn't have access to technology or were really in need of that high touch. This data goes until I think that drops off in March, and we've seen an increase again, but this was a really tricky time for us, which we'll talk about. But you can see for the total distinct number of MRN since we started tracking of almost 1,900 patients, that is 24,000 visits. So it shows how high touch our patients and how many people they're seeing as part of our treatment team. Next slide. So I kind of mentioned this, there are different types of low threshold. Some are low threshold, meaning they're, easy access, but they still may have some more kind of organized intake process. Others may be, low threshold a few days a week or a few hours of a week. What's low threshold about our Bridge Clinic is that our primary goal is engagement, and it's we really put minimal demands on patients. It's just show up as you are. We do very aggressive about same-day pharmacotherapy, pushing the envelope with rapid starts of extended release buprenorphine and sublingual. We offer counseling and coaching, but none of it is mandated. And really the emphasis is on education and support, and lots of harm reduction, HIV, Hep C screening, and plugging them into care. And then this consult and return, as I said. And I would say that the biggest piece is that patients are always welcome and never discharged for active illness. So we're, not someplace where people are being discharged for using. Next slide. This is a note from a patient who was thanking us for not kicking me off as he was navigating his multiple substance use disorders, and he really stabilized beautifully, using much less, keeping them out of the emergency room, fewer injection-related infections, and really started to stabilize and do well. But had we discharged him based on toxicology, we wouldn't have seen this functional improvement and quality of life improvement. Who we are, as I said, we're multidisciplinary. We span the gamut from medical providers to behavioral health support. Most are part-time, but make up FTEs. We had a fabulous clinical pharmacist working with us as well. COVID prevented us from continuing our 7-day-a-week till 9 p.m., which was a nice breath of expansion, not quite the 24-hour emergency room coverage, but we're now 5 days a week with evening coverage, but we haven't gotten our weekends back. And we have addiction medicine fellows, which has also been really terrific. Next slide. Next slide. So who we are, I think we can kind of skip this. I would just say a couple of things about the harm reduction, safer injection kits, nasal naloxone, fentanyl test strips, PEP and PrEP, and referral to treatment. One thing my colleagues and I were talking about earlier, we have not been able to get smoking harm reduction materials, but that's something that's on the docket. We're hoping to get very close to that. And care and resource connection, I mentioned earlier, we're transitional. So we take the onus off the patients. We work to stabilize patients and then meet with them to figure out what type of services do they want. Some want embedded primary care, ongoing support, and maybe a connection with a recovery coach here and there. Others are looking for a more intensive outpatient structured program. And our resource specialists and our team, we meet to kind of figure out how and where the person is living, what insurance they have, and plug them into care that's going to provide them with the greatest success. In order to do that, we've had to vet community programs. There are some that we will not refer to who are not providing the type of care that any of us would want for our patients or for ourselves. And then we've made some really strong community connections for others. We also do follow-up when we refer people out after they've stabilized, and some come back because it's not the right fit, or they have a recurrence of use and the program that they're in may not be the right fit for them, or may not be operationally able to manage their use, even if philosophically they are. So they have 15 patients scheduled back to back in primary care, and their patient who was supposed to come at 9 shows up at 4. It's hard to manage that. So that somebody will take in Bridge Clinic and continue that stabilization. Next slide. And who are our patients? Really, they run the gamut. Anybody with a substance use disorder who's not connected to care or is really struggling with connecting at all. Short-term stabilization, a small subset, we see them, we stabilize them, we plug them in for long-term care. That's gotten easier as our community partners have increased access. A large subset are homeless and psychiatrically ill, and a large subset post-incarceration as well. Next slide. And just who are our patients and what are their needs? As I said, it's the only place that ever cared about people like me. Love the Bridge Clinic. This is a message from one of our patients. So historically, people who have not found other places that have suited their needs. In lieu of time, I'm just going to read you this, I'm going to give you a summary. This is from Mark LaRochelle, a colleague at Boston Medical Center, really a hallmark study where they studied in people post-overdose who had interfaced with the emergency department and found in the year after a non-fatal overdose, only 11% of people got referred for methadone, and it was only for 5 months. 17% were prescribed buprenorphine and they stayed on it only for 4 months, and 6% naltrexone with a median of 1 month. So when we think about treatment, first line therapy is full opioid agonist or partial opioid agonist, methadone and buprenorphine, and really third line agent, it would be naltrexone. And despite the short duration of treatment, however, even though it wasn't as long as we recommend people stay on for this chronic relapsing illness, there was a reduction in all-cause mortality for methadone and buprenorphine, but not for naltrexone. So something to think about, particularly as we care for these patients. Next slide. And then treatment retention is, engagement and retention are really the most important pieces here. If someone doesn't step foot through the door and they're not coming, we're not going to be able to reach them. So the onus is on us to figure ways to do that. And really, this is a great study that showed treatment retention is really more associated strongly with quality of life, irrespective of toxicology results. And that's really goes back to, if we take a snapshot of a toxicology, when somebody may be continuing to use, but using less chaotically, but their actual functional status is improving, we're going to lose all of that and miss all of that improvement as they navigate this chronic relapsing illness, just as we do with other patients for other illnesses. Next slide. And just to leave you with another quote from our study, that trust is so critical for retention and why this works. I guess it's like there's no judgment. I'm not trying, whoops, can you go back? Nikki, can you go back to that slide? Thank you. I guess it's like there's no judgment. I'm not trying to abuse anything. I just need someone to work with me. And I think that's the biggest difference. Here it's like they work with you as opposed to just throwing you on medicine and throwing you out the door. Next slide. And celebrating progress. I walk out of here and feel good about myself instead of getting chastised for relapsing and feeling bad about it. We actually talk about it. I take something away positive instead of just feeling bad about it, like how I screwed up again. Then I just feel bad, and how do I deal with feeling bad? I end up using drugs. So again, there's always, even in the face of use, there's always silver lining. There's always something positive when you're working with people, so that they may come in the door feeling demoralized, but they leave with some hope. Next slide. I'm going to skip this. You can go next slide. So just to end, by us having this really available low threshold care in the Bridge Clinic and throughout our continuum, it really allowed us to support our colleagues in the communities that were doing primary care or in the emergency room, and decant them, and also really model what works. And so it allowed us to expand buprenorphine in our emergency room. So our emergency room colleagues had a place to send people immediately after initiation, immediate access post-incarceration. Our Hope Clinic was modeled out of this clinic. And infectious disease and substance use disorder teams have really been collaborating a lot, and we've been sharing the model locally and nationally, obviously, as you heard today. Next slide. Nikki, tell me, I don't know how I'm doing for time. So our ED, I think, you've heard a lot about the California Bridge. Our ED in 2018 launched their buprenorphine protocol out of this collaboration, where patients get a short take-home pack and then are referred to us. Many come straight to us that day. Some come, within those few days. We have monthly Bridge and emergency room meetings to track our data, see how we're doing, work through challenges. But this has been a real win in collaboration. Next slide. All right, the impact of COVID, okay, 5 minutes, great, thanks, Nikki. The impact of COVID on people who use drugs, I think it's pretty clear. This has been, we're in a devastating worsening of the overdose crisis, multiple substances, homelessness, and the whole nexus of all of these, the trifecta of homelessness, serious mental illness, and substance use disorder. COVID really dramatically hit our model structure, which was come as you are, just show up. Doesn't matter, we'll find a space. With the need to socially distance, we had to reduce our hours. Many of us were sent to COVID units to care for patients, and so we had to decrease staffing. We stayed open, which we're really proud of, but it was an extremely tiny crew with a high volume at times. We were worried about patients, as I showed you earlier, with isolation, and expanding prescriptions was really difficult for some people to manage. On the one hand, for many, it was really liberating, and for others, it was very hard to manage that, and then they would lose them. It would be hard for us to get an override. So we really stockpiled extended release buprenorphine, which I'm happy to talk about later. But we had a real trouble reaching those of our patients who are most marginalized and most at risk. And social distancing and hygiene obviously was really difficult for many. Patients who had COVID flags, who went to the emergency room with symptoms or waiting to go in, then couldn't be seen in our clinic. So we had to be really creative about making sure we could see them or get them tablets. Many patients had decreased tolerance because they didn't have access to the substance they were using, specifically fentanyl. And so they're at increased OD risk. And lack of access to past providers. We were taking on many people who said, I called my doctor and they closed down, I can't get my buprenorphine. So it was a real challenge. Next slide. You can go next slide again. There were some silver linings. As I said earlier, we remained open through the surge with a relatively stable number of unique patients and went to about 70% virtual care. Dr. Khan, you'll be proud. 30% in person, but it was a challenge. We did engage patients who were unable to access other providers. Specifically, we had a large influx from corrections, which was a real win. And the extended release buprenorphine was really wonderful. We had been prescribing it for about a year at that point, so we were very comfortable with rapid starts, but we found people were coming and requesting it, afraid that their pharmacies may run out of sublingual buprenorphine. So that really expanded, and the relaxed restrictive regulations on PAs worked in our favor. And by not having our psychiatric colleagues there, they were doing all telemedicine. It opened up more space for our Hope Clinic and ED colleagues to come into the space. So that was a neat collaboration. Next slide. So wrapping up, lessons learned from doing this work. It's really important as a primary care physician. I individualize in care as I do for primary care patients, and working with teams in a multidisciplinary way. When patients show up and it's kind of drop in, come as you are, we strategically utilize each other. And so it's not that this person has to see a physician and they have to see a recovery coach. If one is busy, we'll kind of flex. We maintain consistent all-team meetings and rounds, so communication is open, and we use Microsoft Teams as a really great way for rapid communication. And we always welcome partners to come in, because there's no better way to improve your own goals than having a partner who may also have similar goals and get them both care. Solicit patient feedback is a huge piece to inform us. And if anybody's thinking about developing a bridge clinic, probably the hardest part of this all work is the transitions. We engage with patients, they engage with us. Many of them have trauma, so the disengagement is very difficult, and we're continually trying to improve that. But in the end, this is really the most wonderful and rewarding work. Next slide. I think that's the end. I'm going to leave you with this quote from a patient. "I came here expecting the same old stuff, like doctors that look down or don't really help. I left amazed and overwhelmed with the amount of support I received. This place kept me from using, and every hospital should have a bridge clinic. It's a groundbreaking and life-saving clinic." And I have, I just downloaded the California Bridge website. It is phenomenal. I am so impressed. They have kind of the blueprint for lots of resources. So I will refer you to them for that. And for a lot of the templates are very similar to what we use. But if you're interested, my contact information is here as well. Thank you.
Thank you so much, Dr. Kehoe. These are fabulous presentations. As we're running a little bit low on time, I'm just kind of gonna go through these next quick slides fast. They will be sent out via email for you all to see and read them appropriately. We have some supplemental resources, and I definitely wanted to get to questions. If anyone had questions that weren't answered during the chat, we're more than happy to try to answer them now if you want to unmute and ask.
Nikki, this is Ariana. I was just going to answer there's a couple of good questions I wanted to clarify, and I'll do that quickly because I already wrote something in the chat.
Yeah.
But so in terms of, there's a question, what volume of patients does your son see per day, and do they document in the EHR? And I answered it, but the volume varies depending on site. And I just wanted to clarify, like my site's a rural site, we're just a community hospital, and but I have a full-time substance use navigator. They'll see 4 patients for opioid use disorder per week on average, but they'll also see patients with alcohol use disorder, stimulant use disorder, and then actually follow patients inpatient as well. And so it just varies depending on site and volume. Many sites have actually multiple substance use navigators now because the work is really hard and they do a lot of phone calls in addition to seeing patients. So I just wanted to clarify that. And then we recommend they all document in the EHR, and they're typically documenting like a DAST or an audit as part of their SBIRT. So our goal is someday that it'll be reimbursable. so meaning they're for sustainability. So, but we do encourage that their work, they are a working professional in the hospital, and that they document as part of the medical record, and that can be very helpful. So I just wanted to answer that one here. And then somebody did also ask about like they said, California Bridge is known for microdosing. And I actually thought we were known for macrodosing,
Yeah.
but
Yeah,
Right.
Josh, maybe, yeah. So Josh, did you want to, I put our resources there just to show our regular algorithm and sort of one of the site examples of how we do cross tapering. But Josh, did you want to talk about that a little bit?
Well, I would say we're definitely, it's interesting. I was sort of surprised to see that comment because we're not advocates of microdosing. We're generally, I mean, definitely a patient-centered approach is the way to go. And if someone is really interested in taking that approach, but most of our patients we're doing routine starts. We're treating that just like heroin, with the exception of making sure patients are in more, usually a little more withdrawal. You get like a COWS of 8 plus for a regular dose. You want to maybe go up to 12 for a fentanyl start, and and coaching that it can be a little bit of more of a rough start is helpful, to just give people a heads up that way. And then you can definitely use and then the micro macro, and that's detailed really well in our guide. If you do have transdermal available, that's a great way to start people. Just put on 2 20 microgram patches, and regardless of what they're in withdrawal, they're in no withdrawal. They just use right before you saw them, no problem. Patches go on, and it just helps give them a gentler start for when they actually do start. Or we have a great guide for how you can just use oral dosing, taking the sublingual and taking it as an oral dose to basically get a microdose effect. But again, this is all second line. First line is really just doing a routine start, just making sure people are in a significant amount of withdrawal before they start, and avoiding that middling dose. So that's the other pitfall, is like, taking the approach that you're going to be like, I'm just going to give a little bit, and that will make this fentanyl start go okay. And we see lots of trouble in that. It's like 60 milligrams. Like, you give a real dose. This whole idea that you're going to give 2 milligrams and that's going to make everything okay has not been a successful strategy that we've seen.
Yeah, I'd love to comment about the microdosing. Because you're right, Josh, we struggle with it. I don't know, I can't remember the last time I saw heroin. We have entirely fentanyl. And the fentanyl has, xylazine, which is a clonidine analog, very long acting. And it's been really difficult. And so I agree with you. We've been doing, we're trying not to do, precipitated withdrawal. The problem is so many people are, and actually having people wait now till they get to a COWS of 12, it takes almost 2 days to see that, and patients can't kind of eke it out. So we're finding we're needing to do much more comfort meds to even get them to that. And the microdosing that we're doing, the Bernese method, we're trying to do more rapid when they're using, and the confusion is people think, oh, you stop the fentanyl and then you microdose. It's like, no. You're still using the whole time, and then you sneak on, and the patient say, oh yeah, I did that in jail. This is how I did it. That's the only way I can do it. So it's so interesting. We're now finding it hard to get people to agree to even do the traditional. So it's just been really, really difficult. Yeah. So what we've tried to do is say, we've extended hours. Once you come in, have a cup of coffee, stay with us. We'll do, 0.5 TID really fast, and then ramp them up. So it's basically your micro macro, because we can't get the transdermal patches approved unless they have a pain diagnosis. So that's one thing we just can't get that, which would be the most patient-centered and the easiest, I would think, because of, as you said, that slow onset they've used. They're there, we slap it on, and then move forward. But the thing we do a lot of, and we keep kind of pushing the envelope. In fact, I saw someone yesterday who said, I use this morning, I don't care, I have to get on the shot, just give it to me. I will accept the risk of getting sick, but you have to give me the Sublocade. So that's something we've done it. We say, here are the risks, here are the benefits, this is, so we're gonna do it. But that's been mixed. On days that people use, if we give the Sublocade, they have precipitated. Yeah. So
have you tried giving like a partial Sublocade?
Yes.
Like giving half?
Yep.
And then giving another half the next visit?
So we can't do that because of the controlled. You can't keep it. And then what we've done, though, is given, instead of the loading dose of the 300, we've done the 100. And so this is that creativity. These are, for everybody here, these are off-label use. But this is, as you see, we're trying to, figure out. So I'd love to know more about the macro, because it sounds to me macro is essentially traditional induction ramping up quickly. But it's not like
definitely giving 16,
not
just really giving a high dose to push through.
But they
quickly.
still have
16
to be in
and then
withdrawal.
another 16. Yeah, once they're in withdrawal. And so much of this is that therapeutic rapport, in the sense that it's going to be a tougher start for most people, and there's so many ways to skin that cat. And if you have a trusting relationship and they know that you're in their corner and you're going to do everything you can with adjunctive medications and, doing something fancy with the Sublocade or transdermal or, you know what I mean? Like, all those things matter, all that signaling into that relationship.
Yeah.
And it's going to be a little bit sucky, and that's okay, because they know that, that they're going to get through it. First of all, it's just a period of rocky period. And then they're going to be, in this other phase of their life that's so amazing. And that there is a real prize at the end. And having that connection and that conversation means almost more than whatever path you choose in conjunction with the patient. Like, because it does get confusing because there's so many different ways to do it. So we still, our supply is, fentanyl is going crazy here too. And we've been able to stick to our guns and just really, not really get into the tapering, these long cross tapers.
And you're in the ED, right? And you're in the ED setting. So you're kind of more, you got to move people. It's like the inpatient setting as well. You got to do it much more quickly. I see somebody said Bernice.
Oh, sorry. Yeah, someone said they used the Bernese method for the first time this weekend, and the client has been successful in staying sober.
Nice.
I've noticed it's been really much easier when we transfer, say, somebody from methadone. The microdosing is really easy, but it's still, with the fentanyl, it's a little tricky, but it's not doable. So it's definitely changed the landscape.
There's also been, like, for me, there's been some folks who had pain, but we used some short actings to help get through. And that's what I just did. And I did an inpatient, and I gave the patient 3 options of 1 day and it'll hurt, but then we'll get there really quickly, 3 days or 7 days. And he chose 3 days, and we were able to successfully move over, use the patch actually for pain, which that patch really helps, I have to say. And then we're able, and we did full dose. We didn't stop, full dose pain meds. So with full agonists, and then we're able to switch over. But Yeah,
Yeah,
so it's like that
that's great.
tiny doses and then switch them over to short actings and then stop and then big dose. That's how we did.
That's brilliant. And in the inpatient setting, that is great because you know what you're getting. It's controlled. It's the street supply that is so much more challenging. So that's great.
And the one thing I'll say about the inpatient and emergency department setting, the Controlled Substance Act allows the administration or dispensing of medications in those settings. And so you can slap a patch on them there, so long as they're within those settings. Outpatient, we're prescribing, and prescribing, we're supposed to use FDA approved medications. When it comes to pain and substance use disorder sort of thing, you as a provider ultimately have that call as to what is this primary, is this pain or is this a substance use disorder? We've been talking a lot about low barrier, and look, the majority of the speakers are kind of on the coast, and Illinois is somewhere in between. Like I said, I went to school in Illinois. One thing I would say from a documentation standpoint, what is the goal of all this? The goal, the first, last, and most enduring goal of opioid use disorder, medication for opioid use disorder treatment is fatal overdose prevention. First, last, enduring. And so long as you can stick with that, you can justify many practices because we're just trying to prevent fatal overdose, whether it's needle exchange, whether it's naloxone administration, OEND, or the low barrier treatment that we're doing. So long as you're clear about the treatment goals, then you can kind of push the boundaries of what would be considered acceptable practice. And you've got many experts here arguing that low barrier treatment is the practice that we all recommend.
Absolutely. Thank you for those comments, Dr. Khan. And as we are very over time, but I so appreciated this great discussion, so I didn't want to interrupt. All of the presenters and facilitators, their information will be on the slides that will be sent out, so you can contact them if you have any further questions, and please check out their great resources, especially CA Bridge. They just have so many and they're very helpful. Just some last minute announcements that the evaluation, I sent the link in the chat, it will be up for 2 weeks. And we hope that even if you're not requesting CMEs or CPEs, that you go ahead and take that evaluation, just provide us feedback for the next series. And the other announcement is our upcoming webinar in November. It'll be the last HOTR-LC series. It'll be on naloxone distribution, harm reduction in hospitals, patient education, community-based services for people who use drugs, and it will be on the drug overdose prevention program that just launched in Illinois to help hospitals and community partners and clinics get naloxone into the hands of their patients and community members. So thank you all for being here, and we hope you have a good rest of your Friday.